Okay, let's unpack this. Imagine a medical test that sounds, absolutely perfect on paper. You have a patient, maybe they have bladder cancer, maybe you're just checking for it. You take a simple urine sample, you look for DNA mutations. If you find them, it's cancer. If you don't, they're clear. Simple, right?
It sounds like the holy grail of diagnostics. I mean, non-invasive, easy to repeat, logically sound. It's supposed to be binary.
Exactly. But here's the twist, and it's a massive one. It turns out that sometimes perfectly healthy people, or patients who are technically cured, have urine that just screams cancer to these tests. The test is picking up a signal, but the signal is, well, it's a lie. Or at least it's not telling the story we think it is.
Right, and that false signal has been the Achilles heel of liquid biopsies for years. It's created this cloud of uncertainty that makes doctors hesitant to trust the data.
Because if you can't trust a positive...
The test is useless. It's worse than useless. It could lead to harm.
So today we are doing a deep dive into a paper that I think finally clears that cloud. It was published in Cell in February 2026, titled Field Effect Informed Urine Liquid Biopsy for Bladder Cancer. The lead authors are William Shi and Kevin Liu from Stanford.
And what they've done here is fascinating because they didn't just try to, make the sequencer more sensitive. They actually stepped back and asked a more fundamental question.
Which was?
What is this biological noise, and can we use math to just subtract it?
It's a detective story where the culprit is the patient's own aging cells. So we are going to deconstruct this paper sentence by sentence. We're going to talk about clonal cystopoiesis, a scary-sounding thing called the field effect, and an algorithm with a very cool name, REFIN-RX.
And the stakes here are incredibly high. We're talking about non-muscle invasive bladder cancer, or NMIBC. The standard treatment is surgery, followed by this bacterial immunotherapy called BCG.
But right now, we kind of treat almost everyone the same.
We do, because we don't know who is cured by the surgery alone and who actually needs the drugs. This paper might finally give us that roadmap to stop over-treating patients.
Okay, so let's start with the villain of this story. Or maybe villain is too strong. Let's call it the decoy, the biological noise.
The decoy, I like that.
The paper introduces a term, clonal cystopoiesis.
Yeah.
What on earth is that?
It's a mouthful, but the concept is, it's profound. Let's break the word down. Cysto refers to the bladder.
Right.
Poiesis means creation or formation. Clonal means identical copies. So essentially it means that as we age, patches of cells in the lining of our bladder start acquiring mutations and cloning themselves.
But these aren't cancer.
No, and that's the critical distinction. These are phenotypically normal cells. If a pathologist looked at them under a microscope, they'd say, that's healthy tissue. It functions like a bladder lining.
But genetically?
Genetically, they have mutations that look exactly like cancer drivers.
And the study actually put numbers to this, right? They looked at urine from 138 people who did not have cancer.
Correct. And the data is striking. If you look at young people, this phenomenon is rare. But as you slide that age bracket up, the graph just curves upward.
So the older you get.
By the time you get to people over 75 years old, about 20% of them, 1 in 5, have these cancer-like mutations floating around in their urine.
1 in 5 healthy 75-year-olds has cancer mutations in their bladder. That is honestly a little terrifying.
It is, but it's also just biology. You might be familiar with a similar concept in the blood called clonal hematopoiesis.
Oh, right.
Think of it like a garden. As the garden gets older, weeds start to pop up. These mutations are the weeds. They're there. They're genetically different from the grass, but they haven't taken over the garden yet. They aren't disease yet.
Okay, I like the weed analogy. So what kind of weeds are we talking about here? Are these just random typos or are they specific?
Oh, they're very specific. The study found that the most common mutation in these healthy aging bladders is in a gene called PLEKHS1. About 9% of the healthy samples had this one.
PHHS1. Sounds like a personalized license plate. But usually that's a gene we associate with bladder cancer, right?
It is. It's a known driver. But interestingly, they found that TERT promoter mutations, which are the absolute hallmark of aggressive bladder cancer, were much less common in these healthy noise samples.
So it's a different pattern?
It's a different pattern. So PHHS1 might be an early precursor, a first hit, or a dandelion that just happens with aging, whereas TERT implies things are getting more serious, like kudzu taking over the yard.
They also looked at the mutational signatures, essentially the fingerprint of what caused the damage.
Right. And this was the smoking gun, pun intended. The signatures they found in these healthy people, specifically signatures SBS1 and SBS5, they match the signatures for aging and smoking.
So the same things that cause cancer.
The exact same causes that drive the cancer are also driving this background noise.
So this is the problem for diagnostics. If I'm a doctor and I run a liquid biopsy on a 75-year-old smoker and I see a PLE-HS1 mutation, I might think, cancer recurrence.
But in reality...
In reality, I might just be seeing clonal cystopoiesis, just the weeds of aging.
Precisely. You get a false positive. You might send that patient for unnecessary surgeries of treatments because the background noise of the bladder looks too much like the signal of the tumor.
Okay, let's do a quick recap of where we are. We're about 5 minutes in.
So point 1, we have this thing called clonal cystopoiesis. It's basically age-related mutations in the healthy bladder lining.
Right, it's common.
Very common. Point 2, 20% of people over 75 have it.
And point 3, these mutations look like cancer mutations, which creates all this biological noise that confuses our tests.
Yep, which leads us to the next layer of complexity.
The field effect. This sounds like something out of science fiction, but in oncology, it's a real headache.
It is. The field effect, or field cancerization, is the idea that a tumor doesn't just pop up in isolation. The entire tissue surface, the field, has been exposed to the same carcinogens, like smoke or chemicals in the urine.
So, sticking with the garden analogy, it's not just that there's one big weed, the tumor. It's that the soil in the whole garden is contaminated.
Exactly. And the study put hard numbers on this. They looked at 51 bladder cancer patients. They sequenced the tumor, but they also sequenced the normal-looking tissue right next to the tumor.
Yeah.
And in 49% of those patients, so basically half that adjacent normal tissue, had some of the exact same mutations as the tumor.
Half the patients. So if you cut out the tumor, but you leave the normal tissue next to it.
That normal tissue is still shedding mutated DNA into the urine.
Wow. And that is why standard urine tests fail.
Yes. They can't tell the difference between the ghost of the tumor you just cut out and the field effect of the remaining tissue. It just creates a fog that hides the truth.
Enter the solution. The researchers developed a tool with a fantastic name, Rephyner-Rx, Rephyner-Rx.
It sounds like a prescription drug, but it's an algorithm. It stands for Recursive Phyton Nomination, Enumeration, and Recovery X. But let's stick to Rephyner-Rx.
Agreed. So how does it solve the problem?
Think of it as background subtraction. It's a statistical filter. To find the real cancer signal, you need to know what the background noise looks like for that specific patient.
Okay.
You take the list of mutations found in the tumor, then you look at a background sample. Any mutation that appears in both the tumor and the background is flagged as field effect or noise. You just subtract it.
So you're only tracking the mutations that are unique to the tumor and not in that background noise.
Correct. But here is the aha moment of the paper. The million-dollar question is, what do you use as the background sample?
I mean, ideally, you'd grab that adjacent normal tissue, right? The scorched earth next to the tumor.
That's what they thought initially. That's the logical first step.
Yeah.
But it turns out that's not good enough. A biopsy of adjacent tissue is just a tiny pinprick. It represents 1 millimeter of the bladder.
But the field effect is everywhere.
It covers the entire bladder surface.
So a single biopsy misses most of the noise. It's like trying to map a forest by looking at one tree.
Exactly. So the researchers had a brilliant idea. Instead of a tissue biopsy, they used post-treatment urine. They took a urine sample after the surgery, after the TURBT removed the visible tumor.
Oh, that is clever.
Yeah.
Because the urine washes over the entire surface of the bladder.
Right. The urine collects the DNA shedding from the entire field. So if you sequence the post-surgery urine, you get a perfect map of all the background noise, all the weeds left behind.
And you feed that into Rephyner-Rx.
You feed that into Rephyner-Rx, you subtract those mutations from your watch list, and what you're left with is an incredibly pure signal for actual cancer recurrence.
And the results were drastic.
Huge. When they used Rephyner-Rx with the post-treatment urine filter, the hazard ratio for predicting recurrence jumped to 12.6.
In plain English, that means.
It means the test became over 12 times more effective at spotting who was actually in danger versus who was just, biologically noisy.
That is the power of cleaning the signal.
It really is. It changes the game from guessing to knowing.
Okay, let's pause for our second recap.
Okay, so the big obstacle is the field effect. Normal tissue shares mutations with the tumor, and that confuses the tests.
Right, and the fix is this algorithm, Rephyner-Rx, which subtracts that background noise.
But the real insight, the key insight, is that you don't need more tissue biopsies. Using urine collected after surgery acts as the perfect background filter because it captures the molecular noise from the entire bladder surface.
So now let's move to the clinical application. This is where the rubber meets the road. They took this shiny new tool and applied it to a real cohort of patients.
They did. They enrolled 61 patients with intermediate or high-risk NMIBC. These are people with serious disease. The standard of care here is, first, you scrape out the tumor, that's the 2-RBT.
And then you give them a course of BCG.
Right. BCG is that immunotherapy derived from tuberculosis bacteria. They put it directly into the bladder.
And it creates this massive immune reaction, right?
Yes, to kill any straggler cancer cells. It's effective, but it's harsh. It causes inflammation, pain, urgency, and there's often a shortage of it, believe it or not.
So the goal is to predict who actually needs it.
Yeah.
What did the study find when they tracked these patients?
They tested urine at 3 points, before surgery, after surgery, but before BCG, and then after BCG.
Yeah.
Pre-surgery urine wasn't great at predicting the future, too much noise, as we discussed. But the post-BCG urine, that was the game changer.
If you still have tumor DNA or ATDNA after all that treatment, you're in trouble.
Big trouble. Sensitivity, 86%. Specificity, 95%. If the test was positive after BCG, those patients had a 90% recurrence rate.
Wow. But here is where it gets really interesting for patient care. Based on this data, they were able to categorize patients into 3 distinct molecular classes. This feels like the most actionable part of the whole paper.
I agree. This is the so what for every urologist listening.
Yeah.
Class 1, the surgical responders. These are about 39% of patients. Their tumor DNA vanished immediately after the surgery. Gone. It never came back.
So the surgeon just got it all.
The surgeon got it all. And yet currently, we give these people 6 weeks of harsh immunotherapy. This data suggests they might be cured by the knife alone.
That's 40% of people potentially being overtreated. Okay, class 2.
Class 2. The BCG responders, this was 28% of the group, they still had tumor DNA after surgery. So the surgeon missed some microscopic cells, but after the BCG treatment, the DNA disappeared.
So the drug actually worked for them.
The drug worked, it cleared the residual disease, and these patients had excellent outcomes, just like the surgical responders.
And that leaves class 3.
Class 3, the non-responders, about 33%, so a third of them. They had DNA after surgery, they took the BCG, they still had DNA after BCG, and as we noted, 90% of them recurred.
So for that third group, the BCG was essentially a waste of time. They needed something stronger, and they needed it sooner.
Exactly. Radical cystectomy, which is removing the bladder, or maybe clinical trials, we lost months treating them with something that just wasn't working.
This classification changes the whole paradigm. Instead of wait and see, it's test and act.
Right. And we've never been able to distinguish group 1, the surgery cured, from group 2, the BCG cured before. Clinically, they look the same, they don't recur, but biologically, they're completely different. One needed the drug, one didn't.
Let's do recap number 3 coming up on minute 15.
Key takeaways. Timing is everything. Testing after BCG is the most accurate predictor of long-term survival.
Okay. And then we have the 3 classes.
Right. We can now separate patients into surgery cured, BCG cured, and resistant.
And the implication here is massive. We are likely overtreating 40% of patients and undertreating the 30% who are resistant. This test could finally sort them out.
Which leads us to the final and perhaps most scientifically dense part of the paper.
The mechanism.
The why. Why do some people respond to BCG while others don't? Why did group 2 clear the cancer but group 3 didn't?
And this is where they went deep into the genomics.
Deep into the DNA and the RNA of the original tumors to find biomarkers. And they found something somewhat counterintuitive. The patients who responded best to BCG had the most mutated, the most mess-up tumors.
Wait, usually more mutations is bad.
Right.
In terms of aggressive growth, often yes. But for immunotherapy like BCG, you want the tumor to look alien.
Ah, I see.
They found that BCG responders had a high tumor mutation burden, TMB. They also had specific mutations in a gene called ERCC2.
And ERCC2 is involved in DNA repair, isn't it?
It is. So if ERCC2 is broken, the cancer cell can't fix its own typos. It just accumulates tons and tons of mutations. To the immune system, this cell looks incredibly weird. It's full of neoantigens, new proteins that shouldn't be there.
Which makes it a glowing target for the T cells that BCG wakes up.
It's like a criminal leaving fingerprints everywhere. The immune system can't miss it.
And the RNA data backed this up.
It did. They looked at the transcriptome, what genes were being expressed. The BCG responders had hot tumors before treatment even started.
Hot meaning inflamed.
Exactly. High interferon signaling. They had a high TSE score,
Yeah.
T cell to stroma enrichment. Basically, it measures the ratio of warrior T cells to the structural wall cells, the stroma. A high score means the tumor is already infiltrated by immune cells. They are sitting there ready to fight, but maybe they just need a little push.
And BCG is the push.
BCG is the push, precisely. Now, contrast this with the surgery responders, group 1. Their tumors were cold.
Low mutation burden, no immune infiltration, so why were they cured?
Because their tumors were likely just less aggressive physically. They weren't infiltrating the bladder wall as deeply. They were just easier to cut out completely. They didn't need the immune system to clean up because the surgeon got it all.
That is a fascinating distinction. So surgery cures the polite tumors. BCG cures the ugly but highly visible tumors.
And the ones that kill you are the ugly and invisible ones, the non-responders. That's a brilliant way to summarize it.
So bringing this all home, this paper, Shi et al., it essentially hands us a new pair of glasses. Before, we were looking at bladder cancer through a fog of this field effect noise.
And by using Refiner X and that post-treatment urine sample, we've wiped the glasses clean. We can finally see the signal.
Imagine the future clinic. A patient comes in for a TURBT. We collect their urine a few weeks later. If it's negative.
If it's negative, maybe you tell them, hey, good news, the surgery got it. Let's sip the BCG and just monitor you.
That saves the patient from side effects, saves the hospital money, and saves the BCG supply for those who really need it.
Yeah, absolutely.
And if the urine is positive, we give them BCG. We check again if it's still positive.
We don't wait for a tumor to grow back. We move to aggressive therapy immediately.
It's the definition of precision medicine. It's moving from one size fits all to treating the biology.
It really is.
Before we sign off, I want to leave our listeners with a provocative thought, something that stuck with me from that first part, the clonal cystopoiesis section.
I think I know where you're going with this.
If 20% of healthy older people have cancer mutations, and we only call it a disease when it forms a lump, are we blurring the line between aging and illness?
It raises a profound philosophical question. We are getting so good at detecting DNA mutations that we are finding disease before it's actually a disease. We have to be incredibly careful not to turn healthy aging into a medical condition.
Just because you find something.
Just because you have a mutation doesn't mean you're sick.
Context is everything. The mutation is just a letter in the book. You have to read the whole story.
Exactly. And that's why tools like Refiner X that filter out that background noise are going to be so essential as we all live longer.
Well, that's it for this deep dive. Stay curious, keep checking the data, and we'll catch you on the next one.